Good evening, everyone, and thank you for joining our Men's Health webinar. We'll start with a few housekeeping items, then I'll introduce our speaker. First, your attendance tonight is completely anonymous to other attendees. No one can see your face or your name, and any comments or questions can only be seen by myself and our speaker. If you wish to ask a question, please type it in the chat box at the lower part of your screen, and all questions will be answered at the end of the presentation. Our presentation tonight will last for approximately 45 minutes to an hour and will be presented by Dr. Marc Siegelbaum from Chesapeake Urology. With that being said, we'll start off tonight's webinar discussing the signs, symptoms, and treatment options for erectile dysfunction and stress urinary incontinence. Dr. Siegelbaum, I will turn it over to you.
Thank you very much, Malia. And thank you everyone for joining tonight. I just wanted to give you little tidbits about my background. I basically am a cancer surgeon. I have been for a long time, basically take care of a lot of prostate cancer, bladder cancer, and kidney cancer. I'm a robotic specialist and have been so for the last 20 years. So when I went into residency, I didn't necessarily perceive myself as an expert in the field of ED or incontinence, but because I was involved in so much and so many of the surgical aspects of those cancers, unfortunately, many of the side effects that can result from a lot of the treatments from surgery and or radiation treatment and or chemotherapy, I decided that I wanted to make myself an expert in those side effects so that I too could correct them if need be. I think it's very empowering if you speak to a patient and you talk to them about the various side effects that they might have. And if you can then not only tell them that you can explain what the issues are, but you know exactly and precisely how to fix them, it is very empowering and comforting for them to have that kind of physician who can do that for them. So I became an expert over the years. I've been in practice now for close to 30 years. So I became an expert over the years in the insertion of penile prosthetics, which we'll talk about tonight, as well as artificial urinary sphincters and male slings. Those are the surgical aspects of some of the things that we're going to talk about tonight. So that's my background, and that's how I got interested in this field. We're going to start off by talking about erectile dysfunction first and making sure that we all understand it and that we're on the same page. What exactly is the definition of it? Well, it's the inability to achieve or maintain an erection firm enough to have sexual intercourse. That's the basic definition. Now let's look and see how common it is. It's way more common than you might think. About 1 in 5 Americans who are older than the age of 20 experience some degree of ED in their lifetime. And if you look further into the statistics and dive a little deeper, more than half of men over the age of 40 have some degree of ED well entrenched. And if you look at it from a population perspective, close to 40 million American men suffer from some degree of ED. What actually happens during an erection and what has to happen during an erection for you to be successful? Well, with arousal, the nerves around the penis become activated. It's from stimulation. The muscles then relax. The muscles that actually surround the blood vessels relax, and blood can then flow into those blood vessels and hence into the penis itself. The additional blood causes the penis to stiffen. And in the process of this happening, the little veins that are inside the penis, which are the little tubes that are responsible for draining the penis, actually become compressed so that they can't drain when the penis is stiff. So there's two things that have to happen. The arteries have to dilate so that blood can flow in. The veins have to be compressed and closed so that the blood cannot flow out. So it's a dynamic process of blood flowing in and not allowing blood to flow out. The top 3 physical causes for erectile dysfunction are vascular, some degree of, usually it's issues with blockage in the inflow arteries into the penis. Diabetes is one of the main causes, and that's most likely and most often because of vascular issues, because diabetes does affect the small blood vessels as well. And the third most common reason for it is medication. basically side effects of medication, is a very significant reason or underlying reason for ED. It can also be as a result of prostate cancer treatment that I alluded to earlier. And by the way, there are a couple of different precursors, different disease entities that can happen. And if patients present with those disease entities, such as diabetes, heart disease, or vascular disease, there's a darn good chance they're ultimately going to wind up having ED as well. And if you look at this little pie chart, you can see that the vascular is 40%, diabetes 30%, medication 15%. And there's little slivers of other reasons for why you can develop ED. One being pelvic surgery or trauma, different neurological diseases, different endocrinological diseases. That means imbalances of hormones. And then there's about a 3% or 1% chance of unknown causes for the ED. Let's talk about ED and diabetes. According to the 2015 census data, about more than 15 million men in the United States have diabetes. So if they have diabetes, there's a huge proportion of those that will also have ED. Patients with diabetes and ED together are less responsive to oral treatments for their ED, those being the Viagras and Cialises and those kinds of medication. In men who have diabetes, ED tends to be more severe and associated with a decreased quality of life compared to those men who don't have diabetes. And finally, as we mentioned before, in some patients, ED may be the only presenting symptom of early diabetes. So if they present with ED, you have to think about diabetes. If they present with diabetes, you have to think about ED. And why does ED result from men that have diabetes? About 60 to 70% of the men who have diabetes, first off, have some degree of neuropathy or nerve damage. Remember from that original diagram that I flashed up here, there has to be proper nerve sensation in the skin and the sensory parts of the penis in order to stimulate this entire cascade of events. So if there's neuropathy or damage to the nerve, the whole cascade can never get off the ground, so to speak. Also, diabetes accelerates damage to the inner lining of the small arteries. So if it damages the small little inflowing arteries to the penis, you're never going to get enough blood flowing in. ED pills, the different medicines like Viagra, Cialis, etc., require stimulation of those nerves and require healthy blood vessels in order for it to work. So if these nerves and blood vessels are damaged because of diabetes, the actual medication, the pills, may not be nearly as effective. What other factors affect ED in men with diabetes? Advancing age makes it worse. How long the diabetes has lasted for. If you have poor sugar control, either your blood sugars are out of control or your hemoglobin A1C is out of control. That will tell you have poor control. If you have underlying vascular disease in addition to the diabetes, if you're on diuretic treatment, because those medications can affect ED. And finally, if you have concomitant heart disease with your diabetes, the combination of platter of those two can really make ED difficult to manage and treat. What about erectile dysfunction and heart disease? Symptoms of heart disease may develop within 2 to 3 years of ED. So again, if patients present with ED, you have to be thinking that there might be some underlying cardiac disease too. And it may be a very, very reasonable thing to consider referring somebody for a full cardiac evaluation if they present with ED. And the severity of ED is very much correlated with the extent of the coronary artery disease, meaning there's multiple different blood vessels that supply the heart. And the more involvement you have of those heart vessels, the more severe the actual ED will be. And finally, ED can precede coronary artery disease in almost 70% of cases. So again, ED may be the only presenting symptom. If it is, you may want to think about sending for a cardiac evaluation. So I talked a lot about that arteries supply the inflow of blood into the penis, and this gives you an idea of what the size of those arteries are compared to other arteries. So the penile artery, if you look at it, is one of the smallest arteries in the body. There are some tinier ones, but they're not responsible for organ survival. But if you look at some of the arteries that supply the heart, they're about 3 to 4 millimeters in diameter. The internal carotid artery, which is one of the main arteries in your neck, is about 5 to 7 millimeters. And the femoral artery, which is the artery that supplies your upper thigh and leg, is 6 to 8 millimeters. So you can see the difference in the size of the diameter of the lumen of these arteries, and you see how the penile arteries can get blocked off pretty easily. How do you reduce your risk for developing ED? Well, you can do that by improving your heart health. And that includes things like changing your diet, less salt, less fatty foods. You can exercise or increase physical activity, weight loss. Smoking is a killer for erectile dysfunction, or penile function, I should say. That has to be minimized. And finally, trying to reduce stress in your life. All of those things in and of themselves will improve your cardiac health and thereby improve your ED health as well. How does low testosterone, which is the main hormone that our testicles as men supply to our bodies, how does that affect things? Well, low testosterone occurs when a man's body produces less than normal amounts of testosterone. And in order for the testicles to produce testosterone, there's a whole cascade of events that has to happen in the pituitary, in the hypothalamus gland of the brain first, which stimulates the pituitary gland, which in turn then stimulates the testicles. So it's a unique and complex chain of events for all that to happen. But if the end result is a low testosterone, that clearly can affect proper erectile function. We see low testosterone levels in men who are generally obese, men who have diabetes, here we go again, men who have high blood pressure, elevated cholesterol levels, prostate disease, and asthma or emphysema. That's just a fact that low testosterone levels are more common in these types of patients. What's the estimate for how many men tend to have low testosterone? Approximately 4 in 10 men over the age of 45 have it. So that's incredibly common. And therefore, it's one of the single most important parameters that we check for men coming in with complaints of ED. For every 10-year increase in age, that means after every decade, the risk of low testosterone increases by 17%. So just by virtue of the fact that you're getting older, you can bet on the fact that your testosterone levels are going to decrease. If you're diagnosed with low testosterone, what can you do? Lots of things. We have testosterone gels, which basically come in a pump bottle or a little gel packet that you can rub onto your shoulders and upper arms, for instance. There are patches that you can put on the skin. There are oral medications now that can be used as a testosterone supplement. And also then finally injections. And we have men that give themselves injections at least once a week. And they find that that works better for them than all of the other methods. There also are testosterone pellets that can be put under the skin in the buttocks region, which lasts for 6 months. And there also are different kinds of injections that we can give in men that have long-acting testosterone that can last as long as 2.5 months. So you'd have to talk to your urological provider about that if we can prove by blood tests that consistently, meaning you need 2 different blood tests to prove it. If they are low, we can treat it because that's an essential part of the cascade that's important for proper erections. Well, what happens with ED and prostate cancer treatment? What goes on there? Well, the nerves and some of the blood vessels that supply the blood to the penis for an erection lie very close to the prostate, and they can be involved in the surgery during prostate cancer treatment. It also can be involved in the radiation treatment for prostate cancer because those nerves live right alongside the prostate. And when you're getting radiation treatment, the radiation beams really cannot separate those nerves from the rest of the prostate. So both kinds of prostate cancer treatment can affect erectile function. And it may affect it on a permanent basis. It could affect it on a temporary basis. And what usually happens is with prostate surgery, there tends to be a dip in the erectile function in the beginning, and it tends to get better and better and better over time. And it's just the opposite with radiation treatment, that it tends to work just fine in the beginning, and it tends to deteriorate over the ensuing 1.5 to 2 years. In either situation, it can be treated, and it can be treated quite similarly. It's not a death sentence as far as erections are concerned, but it's just a fact that treatment for prostate cancer can affect it. So there's a percentage graph over top about sexual dysfunction after radical prostatectomy. And I think the number is probably closer to 50%. And maybe that graph actually reflects it. It says it's anywhere from 25 to 75. But that's probably why I quote 50% affected rates to my men who are having radical prostatectomies, even if it's a robotic radical prostatectomy, it could affect them. And I think 50% is a reasonable number to quote. Again, doesn't matter if it happens, when it happens, it can all be treated. And that's just what I was saying, even with nerve-sparing operations. So when we're doing robotic prostatectomies, the prostate is being imaged under a microscope, and we know exactly where those erectile nerves live, and we try to spare them. We try to dissect them off of the prostate without cutting them and without cauterizing them too much. And in a lot of cases, we can preserve them and hence preserve erections. And if you look in the right lower corner graphic, it's 50% of men with radiation will have some degree of sexual dysfunction. So basically, I quote the exact statistic for no matter which treatment you're opting for prostate cancer, you're going to potentially have a 50% impact on your erectile function. Let's talk a minute about Peyronie's disease. Peyronie's disease is a curvature in the inner layers of the penis, which doesn't allow the penis to completely expand properly. So it expands fully on one side, but doesn't expand fully on the other side. And hence there's going to be some sort of curvature. It happens because these fibrous plaques or little scar tissue bundles form in the inner layers of the penis, and they don't allow it to expand normally as it should. There are treatments for Peyronie's disease, and the most common one is Xiaflex, which is a special injectable that you can inject into the plaque itself, and it causes basically a dissolution or a dissolving of the plaque. There are other treatments as well, but this is the one that probably is the most successful. But some of the other treatments are plication, where basically you put stitches in on the opposite side of the scar tissue to straighten it out, and also penile implants, which we're going to get into in a minute. There's special kind of implants that are devised specifically for men with Peyronie's disease, and or if they have concomitant erectile dysfunction, you can absolutely kill two birds with one stone, and that you can cure their ED with the implant and straighten the penis out with these special implants as well. Let's talk about some other treatment for Peyronie's disease. There's this treatment called extracorporeal shockwave lithotripsy, which is a treatment that we're doing for ED in general. We have found that by giving shockwave treatment to the penile shaft, we stimulate the development of brand new blood vessels, and it works for men and for men who are using the medications like Viagra and Cialis, but those medications are no longer working for them all that well. These electroshock wave treatments, we do them in our office under no anesthesia because it basically feels like a slight vibration. It sounds awful, but it just feels like a vibration. Work pretty well for that group of patients specifically. There's also other stuff on the market, which includes intracavernosal stem cell therapy. You've heard a lot, you may hear a lot about that for multiple different specialists, including orthopedists, where they inject this stuff into your joint to try to regenerate the joints. And also this platelet-rich plasma therapy, where you can inject in a serum that has a lot of platelets in it. Sometimes the high-level athletes use it for recovering and regenerating their joints under a lot of stress. Well, it's also used in the penis as well, but there is not really any conclusive evidence that the latter two things really make much of a difference. Well, what kind of other treatments are there out there for ED? we're going to talk about all of them. Oral medications, the Viagras and Cialises, the injections, vacuum erection devices, urethral suppositories, which really don't work and they're not really used anymore, quite frankly, and penile implants. We're going to talk about each of those individually. The oral medications, and we're talking again about the Viagras and the Cialises. Sorry to keep promoting those two. There are certainly other ones on the market, but those are the ones that are most common to both us participating in this meeting, as well as our children that see in the background of baseball games. For God's sakes, you can't get away from it. But anyway, how do they work? Basically, they work by dilating or stretching open the blood vessels to allow more blood to flow in them. And how effective are they? Approximately 60 to 80% of cases of men will get some benefit and maybe a long-term benefit. That means that 20 to 40% of men don't. And what usually happens is that these pills can stop working over time. That's called developing a tolerance for the medication. The body just isn't stimulated by the medication as much as it used to be. We know that these medications are affected by food, so you're better off taking them on an empty stomach. The most common side effects are headache, facial flushing, and a feeling of reflux or maybe acidy type stomach. You also have to take precautions using any of these medications if you're on alpha blocker therapy, which is basically the medication that many men use for enlarged prostates. It's quite a common medication. Or nitrate medication, which is used for underlying cardiac issues. It's an absolute contraindication to take nitrate medication along with Cialis or Viagra, and it can be, seriously fatal. So we're very careful about screening men for those medications. How does the injectable therapy work? Intracavernous injection therapy is basically taking a teeny tiny little needle and injecting it right into the side of the shaft of the penis, and it goes into that hollow space that I showed you the picture of earlier on. And the medication is delivered right into the vascular space of the penis. So it has similar properties to a Viagra or Cialis, if you will, but because it's injected directly into the source, it has a much more potent, no pun intended, effect, and can work within 5 to 15 minutes or so of injecting it with pretty good quality erections. The downside is you have to inject a needle into your penis every time you want to have intercourse. That's not exactly acceptable for a lot of men, but a lot of men are willing to do it, and the needles that we used to do it with are very tiny, and this is an acceptable way of doing it. It's also not meant to be used more than once or twice a week, absolutely, because it can cause scar tissue in the site. And I think most men who are using it generally use it in that way. About 40% of men, however, over time discontinue the medication because they find it just simply annoying and they want to try something different. The most common side effect is penile pain, prolonged erection. That's definitely an issue, and you potentially have to go to an emergency room to get the antidote. But that's precisely why we start off with real teeny tiny doses of the medication and don't carelessly or recklessly have them use high doses of the medication to start with. You have to build up the dose until you get to the proper level, which means getting an erection suitable for intercourse that lasts for at least 45 minutes to an hour. The most common reason for discontinuation is failed erections, pain, and just the dislike in general of doing it. Vacuum erection devices, what happens there? Basically, it's this plastic cylinder that has a pump on the end of it, and that pump creates a vacuum that basically pulls blood into the penis. And then basically, once the blood is pulled into the penis and you have an adequate erection, a tension ring, or basically a soft rubberized O-ring, is slid down from the actual pump onto the base of the penis to keep the blood inside the penis. Patient satisfaction rather ranges from 68 to 80%. I think that's probably a overstatement of how satisfied they are. It's not that it doesn't work. It's just more a matter of how uncomfortable it is, and also the maneuvers that you have to go through before you actually have sex By the time you get back to the room, sometimes you worry about your partner being asleep. So you have to be willing to do certain things, and you have to become good at it, and practice makes perfect. We do use these vacuum pumps quite often in our men who are recovering from their robotic prostatectomies for prostate cancer. I recommend that they use this at least a couple times a week because it helps to distribute blood into the penis. It preserves penile length, and also certainly they can use it for sexual intercourse as well. I'm going to skip over the urethral suppositories since really no one is actually using them anymore, but we can now talk about penile implants. How does it work? Well, basically, if you look at the pictorial, you can see that there are several components to the device. There's a small ball that's in the scrotal sac. There are two cylinders that go in each of the spongy vascular compartments of the penis. There's two separate compartments. So there's two cylinders, one for each. And then finally, there's a reservoir, which is the part of the device that holds the fluid, that helps pump the fluid from, that is responsible for getting the fluid from the reservoir into the cylinders. So when you squeeze that little pump in the scrotum, fluid is transferred from the reservoir into those cylinders. This is a hydraulic device, makes those cylinders very hard, and hence the penis is hard, and it looks and feels like a completely normal erection. When you're done using it, there's a small release valve on the top of the pump ball. I'm not sure if you can see that in this picture, but you squeeze that little release valve and the fluid is then transferred back from the cylinders into the reservoir, and the penis becomes soft again. About 98% of patients reported excellent or satisfactory erections. The most common side effects are postoperative pain, needless to say, but I warn patients about that. Tell them that they need to take at least a week off. They need to keep it iced down for at least 48 hours. And the second most common side effect is mechanical malfunction, which really only happens in about 5% of patients over the course of the lifetime of the implant. So it's not as common as you think. And I think if you train the patients properly on how to use it, it's pretty significantly durable. There's a stat here at 7 years, 94% of them are still working quite nicely. There are different kinds of penile implants. I just showed you the one that is considered the three-piece implant. That is the Cadillac or the Mercedes-Benz of all implants, because it basically simulates the most natural erection and the most natural flaccidity state. There's a two-piece implant, which basically kind of works similarly, but there's no separate reservoir. I think those devices are pretty decent too, but the erections are not quite as good as the three-piece implant. And then if you have a patient that doesn't want anything mechanical in there and is worried about there being a mechanical malfunction, a hydraulic leak, which by the way is not dangerous, but it just won't work. But if they don't want to have anything mechanical in there, you can put a malleable implant in, which basically is a bendable rod. Remember, there's two chambers in there. You need two of those rods that are put in simultaneously through one little tiny incision, either at the base of the penis underneath or at the base of the penis from where it joins the pubic bone on top. So there's three types of implants that can be considered. By far, though, we use the three-piece implants more often. Getting back to the three-piece implant, most of these implants are treated with a built-in antibiotic. And because it's coated with that antibiotic, the risk of infection is pretty low. And as I said earlier, it's probably the three-piece is probably the best one for simulating or mimicking a natural erection, and it also gives a very natural flaccid state when you're not using it. I'm just going to show you a little video, sort of a tutorial, pictorial video on how this thing sort of works. That's the release valve that I was telling you about. Right. What can you expect for the procedure? The three-piece implant is usually performed almost always as an outpatient procedure under a general anesthetic. It usually takes me between an hour or an hour and 15 minutes to implant one of these devices. It's usually in my hands done through a tiny incision underneath where the penis joins the scrotum. It's about an inch long. And an alternative approach is to do that same small incision at the base of the penis on the top of the penis where it joins the pubic bone. I generally recommend that men take a full week off. I think it's reasonable to just lay low at home and not plan to go to work. After that week, you definitely can go to work. After about 2 weeks, you absolutely can go to the gym type, return to the gym type activities. And it usually we won't let you use it for about 4 to 6 weeks after implanting the device because we want it to heal perfectly. We want to make sure that you have no tenderness remaining at all, and we want to make sure that we can teach you properly how to use it. The cost and coverage for penile implants is actually pretty good. It's covered, almost all insurances do cover it, including Medicare. And we're going to talk about some of the incontinence surgeries. That's commonly covered by insurance and Medicare as well. And usually it's covered with both Medicare and Medicare Advantage in most cases. What are some of the benefits of penile implants? Well, it's a fact that there's 97% patient satisfaction and 98% partner satisfaction with the three-piece implant. It's affordable because it's covered by most insurances. It's long-lasting, it's permanent, and it's completely concealed. Basically, a guy could walk around naked in the gym and no man would ever know that he had one of those in there. It's durable. This is another stat that's showing about 89% of men are still using the same device at 10 years. And it's natural. It's designed to maintain a natural appearance in the erect and flaccid state. It does not interfere with ejaculation or orgasm at all. That's a very common question that men ask. Does it inhibit it? No. If anything, it accentuates it because having an erection makes the orgasm or the ejaculation more intense. And finally, it's spontaneous. Basically, whenever you feel like having an erection, you can. How wonderful is that? And more importantly, it can last as long as you want. It doesn't go down until you push the release valve. So your partner can have multiple orgasms, even though you may, under normal circumstances, have not been able to do that for your partner. So there are some risks associated with any surgery. And basically, your physician, your urologist will let you know if he feels you're a good candidate for it. But some of the risks that can happen with an implant is that it may break, it may not function, the pump may not function, the fluid may not function. There could be a leak in the system. By the way, the fluid that fills the system is just saline or salt water, which is part of your normal body fluid, so it's not dangerous. It may cause pain, although that usually is temporary. And there may be infections, despite the fact that the device is coated with an antibiotic, that we give men intravenous antibiotics before, during, and after, and also oral antibiotics after. They can still develop infections in a small percentage of men. So there are some mild risks. And I just want to leave you with that it's a very common problem. There are a variety of treatment options for it. And penile implants may offer you a long-lasting, very satisfactory solution. Let's move now to male stress incontinence. Just want to make sure we get all of our work in. We have about 10 more minutes, which should be about right. What is stress urinary incontinence? It's basically bladder leakage when a person can't stop urinating or can't stop the flow of urine when they're moving, like with laughing, lifting, bending, coughing, straining. About 500,000 men in the world suffer from stress urinary incontinence. So it's pretty common. And nearly 1 in 20 men over the age of 20 have some degree of stress incontinence. What happens with bladder storage? How does the bladder work and how does it store urine? And how are you normally prevented from becoming incontinent or leaking on yourself? The bladder has to store the urine. The urine has to exit through the urethra to get out. There's a sphincter muscle, which is basically a voluntary skeletal muscle that surrounds the urethra, and that sphincter muscle serves as a valve. And that normally is closed in the state when you're not urinating. When your brain tells your bladder to urinate because it is full, the bladder has to contract. And when the bladder contracts or squeezes, the sphincter muscle or valve has to relax. That has to open, and that allows the urine to pass through the urethra and to the outside. We know that the reason why many men have stress urinary incontinence are because of prostate cancer surgery. Approximately 100, well, not approximately, but 100% of men are going to have some stress urinary incontinence immediately following the surgery. But usually with time, and that could be anywhere from 4 weeks to 4 months, most men become completely continent again, just with time and with doing these special bladder control exercises called Kegel exercises. They should be able to regain their continence back. The statistic that I quote is about 7 or 8% of men who have this operation may have some degree of permanent stress incontinence. And it's those men who will require some type of treatment for it. But stress incontinence also can come from neurological disorders like Parkinson's disease, paraplegia, or brain tumors. Enlarged prostate surgery can sometimes result in stress incontinence, albeit rare. Radiation treatment for prostate cancer can result in stress incontinence, although less than with surgical treatments for prostate cancer. And finally, pelvic trauma can cause stress incontinence. Studies have shown that people suffering from stress urinary incontinence are definitely more depressed. They're distressed, they're emotionally disturbed, they're socially isolated. They definitely have an impact on their entire overall quality of life. Well, what are some of the treatments for male stress urinary incontinence and prostate cancer? About 70,000 radical prostatectomies. That's what I was referring to as robotic prostatectomies. We just do it with a robotic device. But about 70,000 radical prostatectomies are performed each year in our country. And about, as I was saying, about 7% of men may have some persistent leakage at a year. Now, some men may have severe leakage, some men may have a couple of dribbles. So it could be all over the map in terms of how severe the leakage is. And depending on how severe the leakage is, it dictates what procedure we might recommend for them. So some of the short-term treatment options we do for men who have some stress incontinence is reducing their fluid intake to some degree and make sure they have timed voidings, which means every couple of hours they go to the toilet by the clock to make sure they keep their bladders relatively empty. Other interventions we do are those Kegel exercises, which is what I referred to earlier. And those are exercises that we will teach you to do. And also pelvic floor physical therapy and biofeedback are two methods that special physical therapists that are trained in the treatment of male stress incontinence, and females too for that matter, can help you with to make sure that you're doing your exercises properly and can really make an impact on the improvement, if not complete discontinuance of the stress incontinence if you are diligent about doing your training and treatments. And then, of course, you can cope with stress incontinence by using pads and diapers and catheters and penile clamps, none of which are acceptable for most men. It's considered a failure. What are some of the coping solutions? Well, we just talked about them, but those things can become quite a nuisance. It's bulky, it's costly, it's not hygienic, it smells. And basically, it doesn't become acceptable over time. Catheters are not considered really a coping mechanism unless you use a condom catheter. And penile clamps can be used temporarily as you're recovering from surgery, but I prefer that men don't use that because then they're not motivated to do their exercises properly. The other long-term solutions that are surgical solutions are available for stress incontinence when the other conservative solutions don't work. The first surgical option is called a male sling. And this is for men who have 1 to 2 pads per day. So they have the mild stress incontinence. They don't need the artificial urinary sphincter, which we're going to talk about in a minute. but basically they would do well with this type of sling system. And basically it's a system that's implanted through a small incision that's made underneath the scrotum is where that urethra channel is. And basically we wrap the urethra in a piece of mesh, which is the same material that surgeons will use to fix hernias. And we kind of lift the urethra up like a sling or a hammock. And by lifting it up and compressing it a little bit, we can eliminate any dribs and drabs kind of stress incontinence, and men can get rid of their pads. Most patients are continent almost immediately, meaning they have good control. It operates on its own. There's no moving parts. It's not hydraulic. And about 92% of the men said they would have it again if they needed to. And this is a pictorial of what it looks like. It's like a hammock. The urethra lives underneath the pubic bone there. And that's where we place this little hammock. Not a great picture, but it's gives you some idea what it looks like anyway. For men that have more significant degree of incontinence, meaning they're wearing anywhere from 3 to 4 to 5 pads per day or more, they really don't do well with these male sling procedures, and they would do much better with the artificial urinary sphincter, which really is the gold standard treatment that's been around probably for close to 50 years. It's completely undetectable. It is a hydraulic device, but no one would know that you have it in there if they saw you naked, similar to the penile implants. So let me show you what it looks like. This is a 3-piece sort of device too, but it's much, much smaller than the penile implant. If you see, there's a little control pump in the scrotum. Looks a little different than the pump from the penile implant. There's a little cuff. It looks like a teeny tiny blood pressure cuff that encircles or goes around the urethra. And that completely surrounds it, and it closes on itself and stays closed all the time. The third piece of the device is a little ball reservoir that's put in the very similar spot to where the penile implant reservoir was. And that's the fluid, again, that controls the mechanism of this device. So what happens is the little blood pressure cuff is always closed and the urethra is always closed. And that simulates your sphincter that you have, that muscular sphincter. When you feel your bladder is full and you need to urinate, what you have to do to operate this thing is actually get a hold of that very small pump, squeeze that little soft mechanism on the bottom of the pump one time, and what that does is it transfers fluid from the cuff into the reservoir, and that artificial valve opens up. So the urethra opens with it, and the urine can flow freely through it. Within a minute, that cuff automatically repressurizes itself, and it's closed again. So usually when you go for urination, you have to plan on spending a minute to a minute and a half in there. But it's an incredibly ingenious and elegant device that's been around for a long, long time. It's very well time tested. And here's another pictorial video that will show you how this thing works. So you can see that by pumping, the fluid moves away from the cuff into the reservoir, and automatically the fluid will go back from the reservoir into the cuff to close it within about a minute or so. See if I can get this to advance. There we go. So what happens for the artificial urinary sphincter? What can you expect? It too is an outpatient procedure. It takes me about an hour to an hour and 5 minutes to implant them. It involves a small incision underneath the scrotum where the urethra lives, as well as a very small incision in the right or left inguinal groin area to put the reservoir in. It takes a few days to be allowed to return to non-strenuous activity. And similar to the penile prosthetics, we don't let you use it for about 4 to 6 weeks to allow it to completely heal. About 95% of patients are satisfied with their device, and about 90% are satisfied very long term. 90% of patients would have the surgery again. 94% of patients would recommend the device to a friend. So those are some pretty powerful statistics. Insurance coverage for stress urinary incontinence treatment varies, but it's usually pretty good. Incontinence treatment is commonly covered by insurance, and usually there's decent coverage under Medicare and Medicare Advantage policies. So let's talk a little bit about the summary benefits. The ability to achieve continence is absolute. You can urinate when you desire to urinate. It's completely placed inside the body and undetectable. There's high patient satisfaction, and it can help restore normalcy and renewed confidence. I must admit that out of all the patients that I take care of for many different kinds of disease or problem areas, the men who have artificial urinary sphincters implanted are some of the happiest patients that I own. It's very gratifying. There are risks associated with this surgery too, so you have to be aware of them. For the male sling, it may not work over time. It could be that the urethra atrophies or shrinks down a little bit so that the piece of mesh around it loosens a little bit. It could cause retention in the beginning where you can't urinate at all. That happens in about 10% of patients. But if we place a catheter for an extra day or two, it usually almost always resolves completely. There can be some postoperative pain, as with all surgeries. There can be some irritation at the wound site, as with all surgeries. Those are the main ones, if at all. For the artificial sphincter, the possible things that can happen, since it is a device and a hydraulic device, it can fail over time. Especially in men who've had radiation, there can potentially be erosion of the little blood pressure cuff around the urethra. Because what happens, since there's a constant low-grade pressure that's placed on the urethra, it can work its way right through the urethra, but almost usually always in men who have radiation procedures. But it doesn't mean that radiation men can't have this done. You just have to be more careful in those. It too can cause urinary retention, but unlikely. Infection is pretty rare. Just want to just to summarize, stress incontinence is a known side effects of prostate cancer treatment, whether surgery or radiation. There's a variety of treatment options available. Short-term options can be expensive and uncomfortable. The sling or the AUS really could offer a beautiful long-term solution. Well, that's it for my talk. I hope you enjoyed it, and I hope that you found it helpful. I want to take some questions if you would like to send some questions my way. I see one. I don't really see any questions.
I have a
Okay.
few that have come in.
Okay, great.
So the first one I will ask is, can you regain some length with an implant?
Yes, there are certain implants, especially the AMS version called the LGX. It's called the length girth extended, is designed specifically to increase length and increase girth over time. So the answer is yes.
Awesome, thank you. And then how natural does the implant feel? Will I have normal sensations?
You will have absolutely normal sensation once you get over the surgery, and you'll have enhanced ejaculatory sensation because it's always better when you have an erection, whether it's a natural erection or an implant erection. So you'll have enhanced ejaculations, but the sensation is completely normal and is not affected by having an implant.
What are your thoughts on men's health shot clinics?
That shot clinic is basically designed for, it depends which one you're talking about. Those shots are the same shots that I was showing you pictures of for penile injection therapy. But in our area, the shot clinics are, in my opinion, a complete ripoff. And what I mean by that is that if you go see a urologist that gives you a prescription and sends you to a pharmacy who dispenses these medications, you can get those medications relatively cheaply, incredibly relatively cheaply, more cheaply than you think. Some insurances may cover it, but most don't. But even if they don't, it's relatively cheap for a fairly big vial. If you go to these shot clinics, they absolutely overcharge out the wazoo for these special cocktails, these special mixtures that they claim that they have, and they charge a fortune for these usually pre-filled injections. So it's not as if they're not using the proper medication, in my opinion, but it's a complete ripoff cost wise, and they don't support you if there's a problem. So if you have a problem with the medication, which usually, of course, happens at night, it's usually urologists like us that have to see you in the emergency room because there's no one available from their office that could remotely help you. None of them are urologists, and occasionally they're not, most often they're not doctors either. That's my editorial on that. Any other
Um,
questions?
yes, this last one is, do all urologists do IPPs?
They don't. So you really have to check with your urologist to see if they're an expert in doing them or not. Most urologists do not do it because they don't have the expertise for it or they don't have the interest in it. So you really do need to shop around, and you need to look on the websites of various groups. For instance, with Chesapeake Urology, we have an ED website, and it lists all the expert docs that are available in our practice to do implants. So no, most urologists don't do it. Most of them are not trained for it. So you have to make sure and ask questions and ask them how many they do. Uh,
When should, oh yes, you just saw this one pop in.
yeah, when should I ask to increase my injection dose if it is not providing at least 30 minutes for erection? Well, you can do it the very next time. You can increase your dose the next time. If it hasn't worked for you, I probably would give it at least 2 tries. But if it doesn't last for at least 30 minutes, you're probably ready for the next increment.
Awesome. Well, it seems like this concludes our webinar this evening. If there's no further questions, Dr. Siegelbaum, I really enjoyed your expertise and appreciate your time. If there's
Welcome.
any other further questions, please feel free to email the link that you had received after registration. Dr. Siegelbaum had provided his contact information, but aside from that, I appreciate your time and thank you, Dr. Siegelbaum, and everyone have a
You're
wonderful
welcome.
evening.
Have a great night. Thanks for coming, everyone. Bye-bye.
Bye.